So this is a quick one because I'm revising at night. Let me remember. So I'm going to go through some past papers, just the questions I feel like going through, the ones I feel like are common. And I actually asked Gemini to analyze my work and tell me which ones are common. Gemini is not even showing me my history now. Let me wait. Okay, so the common questions are on ADHD, indicators of abnormality, that's literally the 4Ds, personality disorder clusters, mood disorder, bipolar, and depression. There were clinical case studies, ethical and clinical practice. Schizophrenia was also very common here. Major depressive disorder. So the questions I've highlighted are the ones we're going to look at, and then I also have my own document on things I think would come or would be relevant to revise. So question 1 is a case study. Childhood mental illnesses present differently from those in adults and are often influenced by developmental, familial, and sociocultural factors. Using examples of at least 2 common childhood mental disorders, e.g. ADHD, autism spectrum disorder, anxiety disorders, describe the core symptoms of how they manifest in children. I still have to read on autism though, because I think autism might come. So for here, we're going to look at ADHD. Autism is here a little bit. So describe the core symptoms and how they manifest in children. ADHD is a neurodevelopmental disorder characterized by persistent patterns of inattention, hyperactivity, and impulsivity. The core symptoms are easily distracted, difficulty sustaining attention, fidgeting and restlessness, excessive talking, interrupting others, difficulty waiting turns. If you get a question where you're not sure if it's ADHD or autism, you look at the age. If the age is talking about 15 or 12, that's definitely ADHD. If the age is talking about around 2-3 years, even 5 years, and there's a mention of maybe in early life, in the very, very beginning stages of life, something was noticed, that's definitely autism. If there is echolalia, or you read something like the child would always repeat phrases and stuff, that is definitely autism. Manifestation: poor academic performance, incomplete homework, frequent disciplinary problems, difficulty following instructions, peer conflicts. Then for autism spectrum disorder, ASD is a neurodevelopmental disorder characterized by deficits in social communication and restricted repetitive behaviors. Core symptoms: poor eye contact, delayed language development, difficulty understanding social cues, restricted interest, repetitive movements, hand flapping, rocking, resistance to changes in routine. Manifestation would be difficulty making friends, limited imaginative play, distress when routines change, intense focus on specific interests. Then we have the biological, psychological, and social risk factors of the two would be, genetic predisposition, brain developmental abnormalities, prenatal alcohol or drug exposure, premature birth, neurochemical imbalances. Psychological factors: childhood trauma, low self-esteem, emotional dysregulation, insecure attachment, temperament. Social factors: poverty, family conflict, abuse and neglect, bullying, poor parenting practices, community violence, social isolation. That question was: explore the potential biological, psychological, and social risk factors for childhood mental illness. So it's not just ADHD and autism, those are childhood mental illnesses. And then analyze the challenges in diagnosis and early intervention, especially in low-resource or culturally diverse contexts. So we have symptoms overlap with normal childhood behavior. Children may struggle to describe emotions. Comorbidity complicates diagnosis. In autism, a child may not even be able to read facial expressions, and on symptoms overlap with normal childhood behavior, someone may think they just have an active child, a playful child, but that's not the case. Comorbidity complicates diagnosis, limited child mental health specialist, stigma surrounding mental illness. Cultural beliefs may attribute symptoms to spiritual causes or poor discipline. Limited screening tools in low-resource settings. Financial barriers reduce access to assessment and treatment. Then holistic and culturally sensitive treatment would be comprehensive psychological assessment, psychoeducation for parents and teachers, behavioral interventions, family therapy, school-based support, medication when indicated, community awareness to reduce stigma, collaboration with cultural and religious leaders where appropriate, multidisciplinary care involving psychologists, teachers, pediatricians, and social workers. And then the next comment was, explain the major symptoms in schizophrenia. So let's go to comment number 2. Why isn't it moving? Delusions. Fixed false beliefs despite evidence, e.g. persecutory grandiose, hallucinations, perceptions without external stimuli, most commonly auditory hallucinations, disorganized speech. You'll find loose association, tangential speech. Tangential speech is like someone goes on a tangent. They start talking about one thing, but they never come back to that thing. Incoherence, which is word salad. Grossly disorganized or catatonic behavior. I think we may be asked to define or describe catatonia, or it may be brought up as catatonia is seen in 1, 2, 3, explain or something. And I think I have actually mentioned that in previous videos. As we mentioned, grossly disorganized or catatonic behavior, agitation, bizarre behavior, catatonia, that is stupor, mutism, or waxy flexibility. Negative symptoms, these are symptoms, experiences which are removed. Affective flattening, that is reduced emotional expression, alogia, reduced speech, avolition, lack of motivation, anhedonia, inability to experience pleasure. Anhedonia is also a symptom in depression, major depressive disorder. Anhedonia, inability to experience pleasure, asociality, that is social withdrawal. Cognitive symptoms are poor attention, memory deficit, impaired executive functioning, difficulty with planning and problem solving. For diagnosis of schizophrenia, at least 2 characteristic symptoms must be present for a significant portion of 1 month, with one symptom being delusions, hallucinations, or disorganized speech, and there must be continuous signs of the disorder for at least 6 months, causing marked impairment in social, occupation, or academic functioning. Next question. State the major symptom that should be assessed in every depressive patient. That should suicidal ideation, risk of suicide, definitely. Difference between bipolar 1 and bipolar 2 disorder. Bipolar 1 requires at least 1 manic episode, manic. Bipolar 2 requires at least 1 hypomanic episode and 1 major depressive episode. In bipolar 1, major depression is not required. In bipolar 2, major depression is required. Mania lasts at least 7 days or requires hospitalization in bipolar 1. Hypomania lasts at least 4 days in bipolar 2. Severe impairment in functioning in bipolar 1, less severe impairment in bipolar 2. Hospitalization may be necessary in bipolar 1. Hospitalization is uncommon in bipolar 2. Psychotic features may occur during mania in bipolar 1. Psychosis does not occur during hypomania. And there's differential diagnosis of bipolar 1 and schizophrenia, of which in bipolar 1 there is psychotic features during mania. And bipolar 1, more severe illness. Bipolar 2 is seen as generally less severe, but depressive episodes are often more frequent. Summary would be bipolar 1 is mania plus or minus depression. Bipolar 2, hypomania plus depression. Then define the term psychopathology. Psychopathology is a scientific study of mental disorders, including their causes, which you saw in another video means etiology, symptoms, diagnosis, development, treatment, and prevention. It examines abnormal thoughts, emotions, and behaviors that cause significant distress or impairment in functioning. So psychopathology is a scientific study of mental disorders, including their causes, symptoms, diagnosis, treatment, and prevention. Using examples, describe the following terms. So interesting, because even before I did these past papers, I was thinking there are some terms that would come. So we have clinical interview. A clinical interview is a structured or semi-structured conversation between a mental health professional and a client to gather information about symptoms, personal history, mental state, and functioning to aid diagnosis and treatment planning. For example, a psychologist interviews a client presenting with persistent sadness by asking about mood, sleep, appetite, family history, and suicidal thoughts. Mental status examination. A mental status examination is a systemic assessment of a client's current psychological functioning based on observation and interview. It evaluates appearance, behavior, speech, mood and affect, thought process and content, perception, cognition, insight and judgment. A client with schizophrenia may exhibit poor hygiene, disorganized speech, auditory hallucinations, and impaired insight. That's an example. Statistical infrequency. Statistical infrequency refers to behaviors or characteristics that occur very, very rarely in the general population and therefore deviate from the statistical average. It's like they're rare. For example, hearing voices when no one is present is statistically uncommon and may indicate psychosis. Smelling things that nobody can smell, and this is not attributed to any medical condition, that is a sign of psychosis. So hearing things that are not there, smelling things that are not there, seeing what is not there, feeling sensations that are not there, those are signs of psychosis, and that is statistical infrequency. Not all statistically rare behaviors are abnormal, e.g. exceptionally high intelligence. You're not abnormal because you're exceptional intelligence. And then 5 major mental disorders from the DSM-5 TR: major depressive disorder, schizophrenia, bipolar 1 disorder, generalized anxiety disorder, attention deficit hyperactivity disorder, which means maybe ask something about one of those disorders, or at least 2 or 3, or even actually 4, because I really haven't seen generalized anxiety disorder in these past papers, but the rest I have. Then there could also autism spectrum disorder, obsessive compulsive disorder, post-traumatic stress disorder, borderline personality disorder, and panic disorder. Let's go to the next question. Distinguish psychosis in bipolar disorder versus schizophrenia. That is bipolar 1, by the way. In bipolar 1, psychosis occurs only during manic or depressive episodes. That's mood congruent or mood incongruent. In schizophrenia, psychosis is a core feature and can occur independently of mood episodes. In bipolar 1, psychotic symptoms usually resolve when the mood episode improves. In schizophrenia, psychotic symptoms may persist for months and are accompanied by persistent negative symptoms and functional decline. They've explained the major symptoms of schizophrenia. We have delusions, we have hallucinations, we have disorganized speech, we have grossly disorganized or catatonic behavior. Then we have negative symptoms and positive symptoms. We have cognitive symptoms. Again, diagnosis requires at least 2 core symptoms, with one being delusions, hallucinations, or disorganized speech, present for a significant portion of 1 month, with continuous disturbance for at least 6 months, causing marked impairment in functioning. Describe the major categories of personality disorders. These are like the clusters of personality disorders. We have cluster A, B, C. We have cluster A, which is order-eccentric, paranoid personality disorder, schizoid personality disorder, schizotypal personality disorder. The characteristics of cluster A, which is order-eccentric, is suspiciousness, social withdrawal, odd beliefs. Cluster B, dramatic or emotional, and we have 4 personality disorders in cluster B: antisocial personality disorder, borderline personality disorder, histrionic personality disorder, narcissistic personality disorder. The characteristics of cluster B, which are dramatic, emotional, emotional is emotional instability, impulsivity, attention seeking. Cluster C, anxious, fearful. Avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. Obsessive compulsive personality disorder is not the same as obsessive compulsive disorder. Characteristics of cluster C, which is anxious / fearful: anxiety, fearfulness, perfectionism, dependence. State the major symptom that should be assessed in every depressive patient. This one has been repeated again. Every suicidal ideation, risk of suicide. Every patient with depression should be assessed for suicidal thoughts, plans, intent, means, previous attempts. Difference between bipolar 1 and bipolar 2 disorder. Bipolar 1 requires at least 1 manic episode. Bipolar 2 requires at least 1 hypomanic episode. I know I'm repeating. Depression may or may not occur in bipolar 1. Major depressive episode is required in bipolar 2. Mania lasts at least 1 week, equivalent of 7 days in bipolar 1. Hypomania lasts at least 4 days in bipolar 2. Bipolar 1 causes marked impairment. Bipolar 2 does not cause marked impairment. Bipolar 1 hospitalization may be necessary. Bipolar 2 hospitalization usually unnecessary. Bipolar 1 psychotic features may occur. Bipolar 2 psychosis never occurs during hypomania. Remember the differential diagnosis of bipolar 1 and schizophrenia. Psychosis during mania in bipolar 1, and psychosis is a major symptom in schizophrenia. Mania may require emergency treatment in bipolar 1. Symptoms are less severe in bipolar 2. Again, bipolar 1 is mania plus or minus depression. Bipolar 2 is hypomania plus major depression. So you see, depression is not really necessary in bipolar 1 for diagnosis to be met, but it is necessary in bipolar 2 for diagnosis to be met. Okay, let's go to the 8th comment, 8 of 9 comments. Attention deficit hyperactivity disorder. I think this question was talking about give a full report on ADHD. ADHD is a neurodevelopmental disorder characterized by persistent patterns of inattention, hyperactivity, and impulsivity that interfere with functioning. The causes are biological and environmental. So we have biological causes, strong genetic influence, dopamine and norepinephrine dysregulation, brain development differences. Environmental, premature birth, low birth weight, prenatal alcohol or tobacco exposure, lead exposure. There are 3 types of ADHD: predominantly inattentive, predominantly hyperactive, impulsive, combined presentation. Hyperactive impulsive has a hyphen. Symptoms of ADHD: inattention, hyperactivity, impulsivity, divided into 3. So under inattention, we have easily distracted, careless, mistakes, poor organization, forgetfulness, difficulty sustaining attention. Hyperactivity, we have fidgeting, excessive talking, running or climbing excessively, difficulty remaining seated. In impulsivity, we have interrupting others, difficulty waiting turns, acting without thinking. Effects: academic, social, and emotional. In academic, there is poor concentration, low grades, incomplete assignments. In social, we have peer rejection, relationship problems. Emotional, we have low self-esteem, frustration, anxiety, or depression. Assessment for ADHD will be a clinical interview, behavior rating scales, parent and teacher reports, the DSM-5 TR diagnostic criteria. Treatment, we have psychological, medication, education support. So psychological would be behavior therapy, parent training, school interventions, cognitive behavior therapy. That is for older children, by the way. CBT would be for older children with ADHD. Medication, stimulants, I'm not sure I should mention the names of the medication, and non-stimulants. Educational support, individualized learning plans, classroom accommodations, positive reinforcement. And then ADHD is common in Kenya, so increasing awareness has led to more diagnosis. Challenges include stigma, limited access to child mental health services, inadequate specialist assessment, and low public awareness. Early identification in schools and families can improve long-term outcomes. ADHD is a lifelong neurodevelopmental disorder that can be effectively managed through early diagnosis, behavioral interventions, educational support, and appropriate medication. The final comment: discuss 5 symptoms that constitute major depressive disorder. According to the DSM-5 TR, major depressive disorder requires 5 or more symptoms during the same 2-week period. 5 or more symptoms during the same 2-week period, with either depressed mood or loss of interest being present. Depressed mood: the individual feels sad, hopeless, or empty most of the day, nearly every day. For example, persistent crying, feelings of worthlessness and hopelessness, markedly diminished interest or pleasure, anhedonia. Remember, we saw anhedonia in schizophrenia. Loss of enjoyment in activities previously found pleasurable. For example, a person stops enjoying hobbies, social interactions, or work. Significant changes in appetite or weight. So we've seen depressed mood, markedly diminished interest or pleasure, significant changes in appetite or weight gain or weight loss without dieting, or increased or decreased appetite. For example, losing several kilograms because of poor appetite. If the person is losing weight because of dieting, that would not really be a symptom of depression, major depressive disorder. Sleep disturbances may involve insomnia or hypersomnia. Examples: difficulty falling asleep, early morning awakening, sleeping excessively. Fatigue or loss of energy, persistent tiredness despite adequate rest. Persistent tiredness despite adequate rest. Example: difficulty completing routine household or work activities. Other DSM-5 TR symptoms: psychomotor agitation or retardation, feelings of worthlessness or excessive guilt, poor concentration and indecisiveness, recurrent thoughts of death or suicide. Let me put this on flight mode so nobody calls me. Okay, again, other DSM-5 TR symptoms: psychomotor agitation or retardation, feelings of worthlessness or excessive guilt, poor concentration and indecisiveness, recurrent thoughts of death or suicide. Major depressive disorder significantly affects emotional, cognitive, physical, and oh my god, I've moved. Let's see, physical and social functioning. Early diagnosis and treatment improve outcomes. Now I want to see what Gemini told me, because I asked Gemini to summarize it, highlight the common questions in this document, and ask Gemini to list the topics so I can focus on them and give me questions and answers. Question 1, psychological theories. A client is struggling with anxiety and persistent negative thoughts about their future. Contrast how the cognitive theory and the biological theory would explain the cause of this anxiety. The cognitive theory would attribute the anxiety to the client's distorted thinking, such as catastrophic thinking, irrational beliefs, or negative automatic thoughts. Biological theory would attribute the anxiety to abnormalities in biological functioning, such as neurotransmitter imbalances, e.g. norepinephrine or serotonin levels, genetic predisposition, or structural brain differences. And then indicators of abnormality. A man is reported to be walking naked on a busy highway, claiming he is protecting the road from invisible spirits. Identify 2 indicators of abnormality present in this scenario and explain why. I would say this could be a cluster A personality disorder or schizophrenia, since it's a very short case study. And then indicators of abnormal disorder, that is the 4 Ds, that's danger, deviance, distress, and defiance. So I would say danger and deviance, because yeah, it wouldn't be distress, danger, deviance, distress, and danger, deviance, distress, dysfunction. Yeah, I would say there's dysfunction here, there's danger, and there's deviance. But would you really say danger here? Is he harming anyone by walking around naked? Okay, someone may feel sexually harassed or assaulted by seeing him naked, but deviance would be he's walking around naked on a busy highway. He's putting himself in danger, and all the motorists on the road in danger. So there's definitely danger there. Deviance, he's walking naked. And then from invisible spirits, what did we see? Statistical something. I've actually forgotten, but statistical something, because not everyone is going to see invisible spirits. And I'm honestly going to just search for that comment and look for where it said statistical. Let me just find it. Yeah, it was called statistical infrequency. Yeah, him seeing spirits, protecting the road from spirits, that's statistical infrequency. So let's see, the answer to question 2 would be indicators of abnormality, violation of social norms, that's deviance. Walking naked in public violates cultural expectations and social standards of dress and behavior. Loss of reality contact. Claiming to see invisible spirits suggests a failure to distinguish reality from fantasy, similar to the hallucinations or delusions seen in conditions like schizophrenia. Alternative answer, dangerousness, as walking on a busy highway poses a risk of harm to self and others. See, said it. And then differentiation, distinguish between bipolar 1 and bipolar 2 disorder, specifically regarding the required episodes and severity of impairment. For bipolar 1 is very severe and requires hospitalization. Bipolar 2 does not require hospitalization. Bipolar 1, major depressive disorder is not necessary. Bipolar 2, major depressive disorder is necessary. Bipolar 1, mania lasts at least 1 week, but that is 7 days or 1 week. Bipolar 2, hypomania lasts at least 4 days. Bipolar 1 has mania, bipolar 2 has hypomania. Bipolar 1 has psychosis, bipolar 2 does not have psychosis. And the psychosis in bipolar 1 is mood congruent or mood incongruent. Okay, let's see. I'm happy I remember that. Let's see what Gemini told us. Bipolar 1 requires at least 1 manic episode lasting at least 1 week. Psychotic features may occur and marked impairment in functioning is present. Bipolar 2 requires at least 1 hypomanic episode lasting at least 4 days and at least 1 major depressive episode. Impairment is generally... I have moved. Where is impairment? Impairment is generally less severe than in bipolar 1 and hospitalization is rarely required. So hospitalization is rarely required in bipolar 2, but in bipolar 1 it is required. Okay, question 4. ADHD management treatment plan. You're managing a case of a 10-year-old boy with ADHD. Outline 3 non-pharmacological interventions you would include in his treatment plan. I would say, what would I say? Family therapy. The family needs to be there. Something about school accommodations, psychoeducation. But they are forgotten. Let's just see what they say. We have behavior therapy implementing talk. Oh yeah, he's a 10-year-old, so behavior therapy will be needed. Because CBT is for older children. Behavior therapy implementing token economy systems or positive reinforcement, parent management training, teaching parents structured routines and consistent discipline, school-based intervention. So somewhere there with school accommodations, providing preferential seating, breaking tasks into smaller parts or allowing extra time for assignments, cognitive behavioral therapy, helping with organizational skills and emotional regulation appropriate for that. And I'm going to read more on that because cognitive behavior therapy and behavior therapy, they aren't different. They aren't the same. Final question from Gemini. Ethical practice, confidentiality. List 3 specific instances where therapist is ethically and legally permitted to break client confidentiality. When there is posed harm or threat to self, the client, or others. When mandated by the law. When a child, a minor or persons with disability are involved. Supervision. So let's see what Gemini said. Immediate risk of suicide by the client, serious threat to harm another person, duty to warn and protect, suspected child abuse or neglect, suspected abuse of a vulnerable adult or elder, court order requiring the release of records. And now we are going to look at my predictions. I actually think like a clinical psychologist, so my predictions are gonna be, actually I think like someone who's doing a Master of Science, because my predictions are not really how, oh, I need to turn on my Wi-Fi to access it. It tells me please make sure you have an internet connection. So just turned on my Wi-Fi to open it and turn it off. So there were like 12 or 13 questions and I was like, I need to look at them. We have the biopsychosocial model. Let's see, we have the biopsychosocial model. We have a lot of things going on here. So the biopsychosocial model proposed by George Engel in 1977 explains that mental disorders arise from the interaction of biological, psychological, and social factors rather than from a single cause. Components. Biological factors are physical or genetic influences on mental health. For example, genetics, brain injury, hormonal imbalance, neurotransmitter abnormalities, dopamine, serotonin, that is, chronic illness. For example, a woman develops major depressive disorder after childbirth due to hormonal changes and a family history of depression. Yeah, now you see it's important to mention that there's a family history of depression. Otherwise, if you just say a woman develops MDD after childbirth, you'd be like, why would you say MDD and not postpartum depression? You see, psychological factors. These involve thoughts, emotions, personality, coping skills, and learned behaviors. For example, childhood trauma, low self-esteem, negative thinking, poor coping strategies, personality traits. For example, a university student develops anxiety because they constantly think, I will fail every exam. Social factors, environmental and cultural influences. For example, poverty, unemployment, family conflict, bullying, social isolation, discrimination. A teenager develops depression after prolonged bullying at school. So we read that again. The biopsychosocial model explains that mental disorders arise from the interaction of biological, psychological, and social factors rather than from a single case. A clinical example would be a client develops depression because the mother has depression. They believe they are worthless. They recently lost employment. So you see the mother's depression, biological. They believe they're worthless, psychological. They recently lost employment, social. So you see biological, psychological, social. The importance of the biopsychosocial model is that it explains mental illness comprehensively. It guides multidisciplinary treatment. It encourages individualized care, recognizes environmental influences. The psychological model of abnormal behavior explains mental illness as resulting from maladaptive thoughts, emotions, learning experiences, and unconscious conflicts. Major perspectives include the psychodynamic theory by Freud, behavioral theory, cognitive theory, humanistic theory. In the psychodynamic theory, Freud theorized that theorize that mental illness is caused by unconscious conflicts, childhood experiences, defense mechanism. For example, a woman develops anxiety because unresolved childhood trauma resurfaces in adulthood. Behavioral theory calls abnormal behavior is learned. Behavior is learned and behavior can be unlearned, by the way, including love. Love is a behavior and it can be unlearned. It's learned and it can be unlearned. For example, a child bitten by a dog later develops a dog phobia through classical conditioning. Cognitive theory calls faulty thinking causes emotional distress. How you think affects how you feel and also affects how you behave. It's a whole cycle. For example, a depressed client believes everything I do fails. I cancel it. That is not my belief. Humanistic theory causes block personal growth and incongruence between the real self and ideal self. For example, a person experiences depression because they feel they have never achieved their life goals. The history of abnormal psychology. We have the ancient period, Greek period, Middle Ages, and the Renaissance, 18th to 19th century, modern era. I don't feel like reading that. I wrote it because in a previous video I mentioned that, but I needed to look at the biopsychosocial model. Then Asperger's syndrome, it still bothered me ever since that video. It has still bothered me, so I had to put it here. Asperger's syndrome was previously considered a separate disorder but is now included under autism spectrum disorder level 1. By the way, autism spectrum disorder has 3 levels. The third level is really needs help. The second level needs moderate help. And then the first level needs little help. Features: normal intelligence, normal language development, difficulty with social interaction, restricted interest, repetitive behaviors. For example, a child is exceptionally good at mathematics but struggles to understand sarcasm and make friends. Difference from classic autism. Asperger's, there is no language delay. In classic autism, language delay is common. Asperger's, average or above average intelligence. Classic autism may have intellectual disability. Asperger's, better cognitive development. Classic autism has more variables. So remember, Asperger's syndrome is now included under autism spectrum disorder level 1. Differential diagnosis of schizophrenia. Conditions to rule out include bipolar 1 disorder with psychotic features, major depressive disorder with psychotic features, schizoaffective disorder, substance-induced psychotic disorder, delusional disorder, brief psychotic disorder, autism spectrum disorder, medical conditions. For brief psychotic disorder and autism spectrum disorder, I really wouldn't pay attention that much in regards to this exam, but psychosis as a result of other medical conditions, yes, that one there. For example, a client hears voices only during manic episodes. No, that's in bipolar 1. Bipolar 1 and not schizophrenia. Schizophrenia is a chronic psychotic disorder characterized by disturbances in thinking, perception, emotion, and behavior. The DSM-5 tier criteria of schizophrenia is at least 2 symptoms for 1 month, including at least one of delusions, hallucinations, disorganized speech, duration at least 6 months. Symptoms: you have positive symptoms, you have negative symptoms, you have cognitive symptoms, you have disorganized symptoms. Not going into detail because I've already done schizophrenia like 3 times in this video. Treatment of schizophrenia is antipsychotic, CBT for psychosis, family therapy, psychoeducation, rehabilitation. Bipolar 1 versus bipolar 2. Bipolar 1, mania is required. Bipolar 2, hypomania is required. Bipolar 1, depression not necessary. Bipolar 2, major depression required. Bipolar 1, mania lasts at least 7 days, which can be more than 7 days. Bipolar 2, hypomania lasts at least 4 days. In bipolar 1, there is severe impairment. In bipolar 2, there is less impairment. In bipolar 1, psychosis will occur. In bipolar 2, no psychosis during hypomania. In bipolar 1, hospitalization is common. In bipolar 2, usually unnecessary. For example, in bipolar 1, a man stays awake for 6 days, spends all his savings, believes he is a prophet, and is hospitalized. In bipolar 2, a woman has several episodes of major depression and occasionally periods of increased energy lasting 5 days without severe impairment. Positive versus negative symptoms of schizophrenia. Positive symptoms are added experiences. For example, hallucinations, delusions, disorganized speech, disorganized behavior. A good example is hearing voices commenting on one's actions. You're combing your hair and you start hearing voices commenting on your hair. You're dressing up, you hear voices commenting on your dressing. You start doing your work, you hear voices commenting. And not like your own inner voice, not like your mother's voice telling you to sweep or make your bed. You're literally hearing a very critical voice over there. Sometimes that voice is loving to gain your trust. Negative symptoms. These are losses of normal functioning. For example, avolition, allogia, anhedonia, flat affect, asociality. A client spends the entire day in bed with no motivation to eat or interact. Remember, that is also a classic symptom in major depressive disorder. Differential diagnosis of depression. Rule out bipolar disorder, persistent depressive disorder, bereavement, hypothyroidism, substance-induced depression, adjustment disorder, anxiety disorder, schizoaffective disorder. For example, a client reports depression but also has episodes of elevated mood and decreased need for sleep. That would be bipolar disorder and not major depressive disorder. Catatonia. It was also bothering me, so I had to go and look up catatonia. Catatonia is a psychomotor syndrome characterized by marked abnormalities of movement and behavior. The symptoms of catatonia are stupor, mutism, waxy flexibility. Waxy flexibility is where somebody stays in the position they were put. If they were put with their head down like this, or if they just fall like this, they stay like that. Their hands can also stay like this. Waxy, just think of waxy. What does waxy mean? It's kind of like flexible, bendy, and all. So negativism, catalepsy, posturing, echolalia. Echolalia is also in autism. Echopraxia, agitation. For example, a client remains motionless for several hours despite attempts to communicate. Also, during when they're catatonic, they won't blink and their eyes would be watery. They just be like this. They literally can't blink. They're not deciding it. They're not deciding not to blink. Catatonic schizophrenia, previously a subtype of schizophrenia, the DSM-5 triad no longer recognizes subtypes of schizophrenia. Catatonia can occur in schizophrenia, bipolar disorder, depression, medical illnesses. Continuum versus enduring. I was like, what is the difference between continuum and enduring? Continuum, mental health and mental illness exist on a spectrum. Everyone experiences symptoms to varying degrees. For example, everyone experiences anxiety but only severe. Persistent anxiety becomes an anxiety disorder. Enduring, mental disorders are distinct categories. A person either meets diagnostic criteria or does not. For example, a client either meets DSM-5 criteria for schizophrenia or does not. Then SSRIs, selective serotonin reuptake inhibitors. SSRIs are antidepressant medications that increase serotonin levels by blocking its reuptake into the presynaptic neuron. For example, I do not want to mention them. They are used to treat major depression, OCD, PTSD, panic disorder, generalized anxiety disorder, social anxiety. For example, a client with depression starts sertraline and reports improved mood after several weeks. Difference between OCD versus OCPD. Remember, OCD is obsessive compulsive disorder. OCPD is obsessive compulsive personality disorder. OCD is an anxiety disorder. OCPD is a personality disorder. OCD is obsessions and compulsions. OCPD is perfectionism and control. OCD recognizes symptoms are excessive, often has insight. OCPD believes behavior is appropriate, egosyntonic. OCD wants symptoms to stop. OCPD usually sees no problem. OCD has distressing rituals. OCPD has a rigid personality style. For example, a woman who washes her hands 40 times a day daily because she fears contamination has OCD. A manager spends hours arranging files perfectly and expects everyone else to do the same, believing this is simply the correct way to work, has OCPD. Differential diagnosis versus comorbidity. Differential diagnosis is the process of distinguishing between disorders with similar symptoms to determine the single best explanation for the presenting symptoms. For example, a client presents with low mood and fatigue. The clinician considers major depressive disorder, bipolar disorder, hypothyroidism. After assessment, the diagnosis is major depressive disorder. Comorbidity is the presence of two or more disorders occurring simultaneously in the same individual. For example, a client has major depressive disorder and generalized anxiety disorder. Another example is a child has ADHD and oppositional defiant disorder. Don't worry about that last disorder. So yeah, that's it. I'm now going to sit down and go through the class given notes, then also go through my own notes for revision. I don't want to fail. I'm winning. I'm passing this exam.